Physiology. So there's a normal physiology and the abnormal or pathophysiological pain. The normal physiological pain mainly usually is nociceptive. Examples are post-trauma or post-surgical, which is acute, subacute, or inflammatory pain, like acute appendicitis. Abnormal or pathophysiologically pain, like neuropathic pain or central pain. The central pain examples are actually post-stroke pain. The physiology of nociception. Nociceptors are actually usually are free nerve endings. It's usually innervated mainly by the alpha A delta fibers and the C fibers that usually respond to the intense and potentially damaging stimuli that exist throughout the body. They're found mainly in the skin. They have a high threshold mechanoreceptors and polymotor receptors, as well as silent receptors. As we can see, the chemical or neurochemical, or what we call the trauma juices that will be released when you have a trauma. For instance, someone hits you in the hand and it's painful stimuli, you will have a release of substance B, glutamate, aspartate at the nerve ending from the presynaptic to the postsynaptic. Other examples are enkephalins, endorphins, norepinephrine, and each one have an effect on the nociception. The excitatory effect examples are substance B, glutamate, and aspartate, which is classic. The inhibitory effect, which usually after completing the loop through the spinal cord, going to the perception of the brain and going back through the descending pathways, norepinephrine and serotonin, which is inhibitory either at the spinal cord or peripheral. So the release of prostaglandin usually potentiate the action of bradykinin and acts as a sensitizer to the nociceptors. The first order neuron, if we're going to go through this in the diagram, which is the nociceptive afferent fibers that usually terminates in the spinal dorsal horn, in the same side of the dorsal root ganglia where the primary sensory neural cells are located. We'll look at the rax laminae, and as you can see, these are actually divided into areas from 1 to 5 or even more than that. But if you look at the dorsal horn, or the posterior part of that area, they're divided into multiple sides, but the mechanoreception usually is at 4, and there is actually various somatic and visceral nociceptor and mechanoreceptors in area 5. As you can see, the input comes in from different fibers, either A delta or C fibers, and this is actually the diagram and the table that shows you different sort of areas with the receptors available on it. So we'll get back to the same diagram that I showed previously in the acute pain management lecture. Perception or trauma to the skin, you'll have your nociception or nociceptor actually activated, release of the chemicals, go to the nerve endings, you'll get the response or the perception of the signal traveling all the way to the spinal cord to the dorsal horn, goes to the contralateral dorsal root ganglion, into the spinal thalamic, ascending roots to the brain, to the thalamic and the cerebral cortex, where they perceive, you feel the pain, or you get to know what, oh, I have pain in my body. Then you'll have the descending modulation part. And as you can see in the arrows, you can see the small little different pharmacological agent that we use that targets certain areas to try and block pain feeling. So that skin, local infiltration, anti-inflammatory drugs like non-steroidal anti-inflammatory, local, usually at the peripheral nerves. You can use local spinally or epidurally. You can use alpha-2 agonist. Examples are epinephrine or clonidine or dexmedetomidine. Opioids also act centrally in the brain central nervous system as well, not at the spinal root, and so on and so forth. Second order neuron, which contains mainly wide dynamic range neurons, nociceptive specific neurons, and they are located in lamina 5 in the dorsal horn. Modulation of pain usually occurs at the nociceptors at the spinal level or in the supraspinal structures, as we showed in the diagram previously, and it can either facilitate or inhibit. So there is both a dual effect at the spinal level modulation, usually via what we think, we're not quite sure, one of the most famous theories is the gate theory by Melzack and Wall. And this is actually in the 1960s. developed, if I'm not mistaken, 1963, there was actually a description of the physiological mechanism by which psychological factors can affect really the experience of pain. So the neuronal gate will open and close usually at the modulating part of the spinal cord. So the gate is usually located at the spinal cord, and it opens and closes